Okay, so today, as I mentioned, today we'll talk about burn rehabilitation. I'm doing burn rehabilitation at King Abdulaziz Medical City in Riyadh. And this is considered the most famous burn unit all over the Gulf area. And if we talk about burn rehabilitation, it's mainly concerned with improving the quality of life, in helping redesigning and rechallenging of patients' life physically and psychosocially as well. The aim of the presentation is mainly an overview about burn rehabilitation, different types of assessments and treatments as well. And I would say the big challenge we do in our facility is we have a deal with all the plastic surgeons that they never do contracture release unless they refer patients to rehabilitation first. And we really do a lot of success in that area as well. The other aim is mainly, I will focus on some challenges and contextual issues that affecting health and well-being for burn patients. I know it will be focused mainly in Saudi Arabia, but I think it will affect the Middle East as well. So in our facility, we have 2 burn units. We used to have 1 burn unit for adults and pediatric. Lately, we have 2 separate burn unit ICU sitting. And then if we have some crisis, we do admit patients in the medical wards as well. So if we talk about the status quo, I think I'm gonna quit that because of the timing, but it's worth saying that 5% of the Saudi children are burned because we have a lot of facilities that they cause burn, like it's very easy to buy some chemicals that cause full thickness burn. Up there, it's very cheap. I know it's limited in Egypt, but in Saudi Arabia, it's very common. Firecrackers as well and fireworks are very common there. I know they're not allowing it lately, but it's still existing in the market. So in Eid and festivals, we used to wait for a lot of patients, especially with children. Also easy to have some sources of barbecuing using gasoline and tinder. Instead of using the cubes. This is also one of the reasons that cause some burns. Scald burn is very common as well, especially for us as housewives. Children, especially in the reaching age, and then they go to the kitchen and then they pull the containers of soup and stuff like that. So early marriage as well in Saudi Arabia is also affecting burn patients, especially with those young mothers that sometimes they take a baby and then they shower him under hot water, because our habit is always like put the hot water first and then you get the cold water and then you adjust them. For the burning issues, we know that very well that burn affects our sense of being whole and how we live inside our bodies. And burn is a threat to body boundaries, and it compromises the psychological and self-body boundaries, also help in distinguishing inner psychological and personal from the world. Burn also affecting resuming life roles, accessing social interaction as well, and it really affects it very badly. That's why most of the patients who got face burn, sometimes they come to our facility again with the suicidal attempt, which is really painful. So the psychosocial role of burn patients, it's always interwoven with the physical treatment as well. So they always start together from day 1 of admission. Lack of coping skills and support systems affect psychological adjustment for burn patients, especially if you are not working in a team. That's why teamwork is very important. And teamwork starts from physicians, nurses, dietitians, physical therapists, occupational therapists. Nurses are playing a huge role. And then we have, in Paris, I've seen also that they have a beauty therapist as well, that they come as volunteers in burn unit. Sometimes they do some makeup and stuff for ladies and children, just grooming and stuff like that. And then we have also, as part of our team, is volunteers. We have a lot of volunteers. Yani, for example, I have volunteers like 15 and 20 years ago, and they still come to the facility whenever we ask them to come and help other patients and show them their skin, and then they talk about the trip that they went through. And it's worth saying that burn patients take a full 24 months for rehab treatment. It will never be less than this, although it's in the evidence. Some patients show some results within 6 months, which is very, very minimal and rare. Some burn patients as well, they develop, they cannot find the job easily. And lately we have in the law that they prioritize some jobs for the disability patients. And just in the last 2 years, we were able to involve burn patients as part of the disabled, especially if they have some physical disability, which is very rare, I would say, and some social and psychosocial impairment as well. At the same time, they have a very minimal chance of marriage as well, and I think it's very common, even with other burn patients. I think because of the lack of burn camps, wherein we meet like medical team with burn patients, and then we go for a camp. In 2007, we have a camp in Asyut, in the university hospital with Dr. Atif, Allah yarhamu. We used to do a lot of activities in Africa, in Ghana and Nigeria, and also in Cape Town, in Tigerberg Hospital as well. So if we just summarize what we are doing for burn patients, is mainly like positioning from day one of admission. In positioning, we used to say we position patient in the shoulders should be in 90 degrees of abduction, hips in 20 degrees. If the patient is having circumferential or dorsal hand burn, so the hand should be in the pussy position, which the wrist should be in 35 degrees, MCB should be in 50 to 70 degrees of flexion, fingers should be in extension, and then the thumb should be in the maximum palmar abduction. With palmar burn, we do the opposite, so the hand should be in complete extension. Feet should be in the 90 degrees as well, and then with this type of positioning, we need the splinting. So by management of edema, we need to position the patient in a position wherein the edema will be subsided. For example, if the edema is too massive to position patient that it doesn't come down, what we do, we tie patient in a hand splint and then in the drip stand. So the hands will be completely elevated, considering shoulder not to be more than 90 degrees of abduction. Because if you position the shoulder in more than 90 degrees of abduction for a whole night, patient will wake up with drop rest, and then he might develop radial palsy deformity. Then we do splinting from day one of admission. Rehab team is doing splinting, custom made on the patient himself. So we do mouth splints, hand splints, elbows, shoulders. We do knees, and then we do feet, like from up to down. It's all custom made splinting materials we use. Sometimes we use ready-made ones, but if the patient is oozing or a lot of leakage is coming down, we never use soft materials because it will be a source of infection by the end. And then we work on assistive devices if patient cannot do his ADL or eat and drink by himself. Sometimes we give big handle utilities. And then we work on therapeutic, mainly OT is doing upper limb exercises for burn patients, and then physiotherapy do lower limbs and ambulation, endurance, and gait training. And then we do ADL as well, and this could be in a later stage. Like if we divide the stages of burn rehabilitation, I would say the acute phase, wherein you do positioning, splinting, active exercises if the patient is awake, and then passive range of motion, very gentle exercises if the patient is intubated and sedated. And then in a later stage of the presentation, we'll talk about exercises and how we do it and the side effects. And then we do scar management, and the scar management just starts in the maturation phase. So if you divide, as I mentioned, burn patients in the acute phase, wherein we do positioning and splinting exercise, and then we go to the proliferative phase, wherein patient goes for a skin graft, and then he goes for wound healing process, and then we do immobilize patients with the splint. Sometimes we go to the OR itself and do the splint inside the OR, and sometimes doctors will ask us to do the splints prior to the operation, and then we'll consider the amount of bandaging around, and then we'll make a space inside the splint. Once the patient is immobilized for 10 days post-skin graft, this is the time we'll start and resume our therapy again. So if patient is doing the graft, 10 days hold for the area that grafted, but we do other treatment for the other parts that it has not been grafted. With the scar management in the maturation phase, this is the area that takes really a lot of time, because this is where in the fibroblast cells get active, and then it would produce a lot of collagen fibers that goes inside the skin and make it thicker and puckered and then short, and then this is what will affect the joint limitation. If the burn is near a joint or overlapping a joint, contractures will occur. With the scar management, we use a lot of modalities. Rehab staff are well educated and well trained and certified for wound care, because sometimes at any stage of dealing with burn patients, any blisters could occur. بيحصل فقاعات صغيرة نتيجة إيش؟ نتيجة إن بيكون عندي الإبيدرمال والديرمال لاير بيكون بينهم بيزمنت ممبرين أو اللي هي الفيبرونكتين deposition بيكون عالي جدا، فبتطلع لسقف الجلد وبعدين تسوي بلستر فقاعات. فأنا كريهاب person I need to be aware about wound care. Once there is something like that, I need to know how to manage that type of wounds. Then we do early wrapping, like الهاندز for example. احنا بنبدأ في الهاندز usually 10 days post skin graft. hands وفيت بنبدأ بحاجة اسمها cobanning. Cobanning is a special cohesive tape that we use to apply pressure, and then we control the amount of pressure while you are using it. So we do wound care, and then we do cobanning. And then from there, we will start the active exercises. And then once patient is ready for pressure, we apply something called interim pressure, which is a ready-made pressure on the shelf, and then we measure patients, and then we just fit him for pressure while patient is still under the wound care for the remaining scattered wounds. And then once patient is ready for measurements, we measure him for custom-made pressure, which we usually buy it from Spain. Then it comes the process of silicone gel sheeting. There is a lot of materials in the markets. I've seen a lot of materials here in Egypt as well. But up there, we develop even some more materials, and we are undergoing for more researches in that area. The psychosocial support is very important because it's always accompanied by all phases of burn rehabilitation. So this is mainly positioning, which I talked earlier about. Usually nurses are very familiar with positioning, but we as a rehab team, we used to give them more advices. For splinting, I used to say splinting, in fact, I'm doing a lot of splinting courses as well with different type of materials for hand therapy and for burn patients as well. So splinting is a science, and it's a technique, it's a skill. At the same time, it's an art. Once you fabricate a splint, you feel like it's a piece of art that you've designed. كأنك نحات أو رسام. This type of splints, like for example, this one is a custom-made neck collar, MCB knuckle splint for hyperextension for the MCB, and this is elbow splint. With the splinting elbows and knees, we need to consider always that the splint shouldn't keep, or even splinting any case, like a head injury or any other case, we shouldn't splint the joint in full extension, because by this way you are blocking the joint space. And with the long immobility for those patients, you can develop easily heterotrophic ossification. So this is mainly some types of splint that I do fabricate them for patients. Like also ear piercing. Ear piercing is a very common type of scar that we used to see quite a lot, especially with the teenagers who go for ear piercing and then it's infected, and then the keloid will start very badly. So there is a special type of splint that we fabricate for that, and it should be worn for at least 6 months. So splinting, we have mainly either static splints, which we use to fabricate in the acute and the proliferative phase, and then in the maturation phase, wherein the skin integrity goes higher, this is the time you can fabricate dynamic splints. And this is mainly for the hand, I would say. And then we have soft splints, like the flexion glove in the middle photo. And then we have the thermoplastic splint, which is the material that we heat in either in water, that the temperature is like 70 degrees, or we heat it on a dry heater. I will quote this as well. And then the splints consideration, it shouldn't cause any pain. It should be very comfortable. It should be functional. It should be cosmetically appealing. It should be easy for dons and offs, and it should be lightweight and low profile. It should be with an appropriate material, because in the market there is more than 8 to 10 materials, different materials. For example, if you have a BIB joint, you will not use that material for BIB joint rather than the hand splint or a knee splint. So it depends on what type of splint you are fabricating, and according to that you will use the material. For the face, we lately we are not using the face mask, the elastic material anymore, because we are mainly doing a crystal material which is transparent, and then we fabricate it on the patient himself. For pediatrics, we used to consider patient comfort during the session, because it will be a little bit hot to fabricate it. Like, patient should wait till it gets cold in his face. With adults, we prepare patients very well before as well. And ventilation and respiration is very important to consider it in the splint, because we don't want a lot of accumulation of fluids or anything with the splints. This is mainly I'll just finish the part of splinting, and then we might continue the lecture again. We will continue the remaining again today, because I have a lot of stuff to say, and you will be happy by the end. With the splinting as well, like the left hand side, في mic. I'll try to be very quickly. For example, this is, this is an extension hand splint for palmar burn. What's inside the red one? This is elastomer. So it's like a silicone that you mold. It's like a pastry and then catalyst. You mix them together and you paste them كأنك تسوي عجينة. And then you spread it inside the splint. This is for night time, and patients should wear it every night. And then the pressure at daytime. This is elbow, this is mouth splint, this two, we fabricate them as well. This is a blue boot, it's already made, foot splint, pussy hand splint, and then we have the anti-claw hand splint. Whoever is interested in a later stage, I could show them the video how to fabricate those types of splints. Then we have dynamic splints. It could be soft, like the flexion glove with ruband, or it could be dynamic with springs and some joints. And then this type of splints, we prefer to use them once patient is fitted for pressure garment. This is just an idea of
دكتورة أماني. دكتورة أماني. نشكر حضرتك دكتورة أماني.
خلاص. So splinting we finish with it, and the remaining inshallah will continue later on.
إن شاء الله. شكرا ألف شكر دكتورة أماني شهاب، وإن شاء الله نكمل بقية المحاضرة بعد الصلاة.